Well, good morning, everybody, and thank you, Gavin, for the introduction. Thank you to the Progressive Public Health Association for putting on this conference, and thank you all for coming. Those of you who've come from this country, and especially a warm welcome to people coming from overseas, and grateful thanks also especially to the Cancer Council, Heart Foundation, and the Australian Council on Smoking and Health for renewing my commitment to harm reduction, never in doubt, but renewing it by their grubby and reprehensible attacks on this conference and people taking part in it. That really shouldn't ever have any place in public health. But I thank you for making sure that we are all even more determined than before to press on with harm reduction. All right, I'm going to say a few words about the history and development of harm reduction, and thank you for pointing out how to operate this not very difficult instrument. So we're going to talk about what actually is harm reduction, when did it start, does harm reduction work, why is harm reduction so often so controversial, how has harm reduction been implemented around the world, and then a few concluding remarks. Now, I'd put to you, before we actually talk about this, that harm reduction really always should be front and centre of drug policy. And if it's not front and centre, you can be sure that the policymakers, the politicians and the community are going to make some dreadful and very expensive mistakes. Expensive in terms of premature lives lost. It's a term that is not that complicated to understand, but it's often poorly understood, often deliberately misunderstood. It's basically just a form of risk mitigation, that is, managing risk. That's really all it is. It's a situation, an approach where where reducing harm is regarded as more important than reducing drug use. So often the real choice is between reducing harm or reducing drug use. It's a pragmatic approach, in other words, a practical way of approaching some difficult problems. And in contrast, people opposed to harm reduction are often out to achieve abstinence from that drug, whatever the cost is. It's non-judgmental. It accepts people where they are. It doesn't condemn people for their particular drug of preference or their particular behaviour. It's an approach which is bottom-up rather than top-down. So decisions are made by people like us about issues that affect our lives rather than relying on a group of people whose names we don't know, meeting somewhere in New York or Vienna or Geneva, who are making decisions on behalf of the whole world. So we want local decisions made by people whose lives are being affected. It's inclusive. It means that health professionals work together as equals with people whose risk behaviour is a matter of concern in terms of possible effects on public health. And it really values incremental gains. Heroic gains are, of course, also welcome, but they don't occur very often. Mostly when we change our behaviour, we make multiple small changes rather than just a few huge ones. And we should welcome those incremental gains. They're very important. Often that's all that we can achieve. And remember also that harm reduction is not only about reducing the harm from drugs, it's also about reducing the harm from drug policies, because drug policy very often is very harmful and often even more harmful than the drugs themselves. Two basic aspects of harm reduction are it's about protecting human rights. Whenever the human rights of a group of people are breached, are threatened, you can be sure that there will be serious public health consequences as a result. And we saw that in spades when we looked at the early years of the HIV epidemic, And the three populations in Western countries who were most at risk: men who had sex with men, men and women who used drugs, men and women who sold sex. Those three groups were seriously threatened for centuries. Their human rights were breached egregiously. And those were indeed, in Western countries, the groups most at risk of HIV. That wasn't an accident. The second fundamental underpinning of harm reduction is to base policy and practice on evidence. Both of those are fundamental to harm reduction and non-negotiable. Harm reduction is about the world we actually live in rather than the world some people would like us to live in. So it's very much rooted in the world of today. Harm reduction is harm reduction is a simple concept, but it's often elusive. It's hard to explain. And one way of explaining this is to say that it's better to have 80% of something than 100% of nothing. That seems to get the message across. It's better to set suboptimal goals and make sure we achieve them rather than setting utopian goals but failing to reach those utopian goals. This is a dilemma that policymakers often have, and it's critical. We set goals that we can actually reach and then go out and reach them. Never let the best be the enemy of the good, saying that originally comes from France, is fundamental to this whole concept. We can't eliminate risk, but we certainly can reduce risk. Let me give you some examples of drug harm reduction. There are many other forms of non-drug harm reduction we can also talk about. Let's start with tobacco. The idea of nicotine replacement therapy is pure harm reduction. People are getting the addicting drug, namely nicotine, without the tars and smoke and carbon monoxide and all the rest of it. And this has been around for several decades and it's been non-controversial. Trouble is, it doesn't really work all that well. But the three major strands of today's tobacco harm reduction, that is vaping or electronic cigarettes, snus, which began in Sweden a couple of 100 years ago and involves putting a tea bag-like apparatus in the upper lip area, slowly releasing nicotine. That's a proven method of tobacco harm reduction, and even that is banned in every other European Union country apart from Sweden. Sweden's the only country where that's allowed, and it has been demonstrated to reduce harm massively among Swedish men. And the third type of tobacco harm reduction is heated tobacco products. We'll probably hear more about these later on. These are things like IQOS and other products. So they're all examples of tobacco harm reduction. Alcohol harm reduction we don't often talk about, but it's actually a very important part of public policy for alcohol. In licensed premises, or pubs as we call them, we often see heavy furniture bolted to the floor so that people with that dangerous combination of alcohol plus a Y chromosome can't pick up the furniture and throw it at other intoxicated people with a Y chromosome. Serving food and soft drinks in pubs is also harm reduction. We're not altering the consumption of the dangerous drug, alcohol, and alcohol is a dangerous drug, but by serving food and soft drinks, we are reducing the harm from alcohol without any doubt. In many licensed premises, glass drinking vessels are replaced by plastic vessels, and the reason for that is that the glass containers can be broken, again by intoxicated people with a Y chromosome, and used as shards or knives to inflict serious injury on other people. So having plastic drinking vessels is harm reduction. And in Australia in the early 1990s, we began to enrich flour in this country with thiamine, a B vitamin, to prevent WKS, that's Wernicke-Korsakoff syndrome, a serious form of brain damage that we see in some people who drink heavily and don't attend to their diet. And at that time when that was introduced, Australia had an extraordinarily high level of that brain disease, and that brain disease has almost been completely eliminated in Australia just simply by enriching flour with thiamine. Prescription drugs, we really need to do much more work on this area, but the longer acting rather than the shorter acting benzodiazepines is a step in the right direction. And arguably, legal cannabis reduces drug overdose deaths. A famous paper in JAMA, the Journal of the American Medical Association, 5 years ago by Bachhuber, showed that in US states where medicinal cannabis was lawful, the mortality from the death rate from drug overdose was 25% lower than in states where medicinal cannabis was still unlawful. And in those states that had introduced this policy of lawful medicinal cannabis earlier, the overdose death rate was lower than in states that had only recently introduced this. And there's a lot of other work that's come out in the last 5 years to further support this notion. But we do need to do much more work on the area of reducing the harm from prescription drugs. Illicit drugs, this is the area where we have, as Donald Rumsfeld would say, a target-rich environment for harm reduction. And the methadone treatment for people with severe heroin problems was introduced over half a century ago in New York City, and now over 80 countries around the world have methadone programs, and they have without any doubt improved the lives, saved the lives of many people who have severe heroin problems, benefited their families, and also helped their communities. Needle syringe programs, likewise, in over 80, 90 countries around the world, and they have, I reviewed the evidence for these for the World Health Organization 15 years ago, and the evidence is really overwhelmingly strong that needle syringe programs are effective in reducing the spread of HIV among and from people who inject drugs, and they have many other benefits as well, and they have minimal adverse effects, and they are highly cost effective. Drug consumption rooms, as we heard from the Minister just a moment ago, we need more of these all around the world. We need many more of these, especially in Australia, and they certainly are very effective. But like many other harm reduction measures, requires a huge amount of effort to get these up and running, and even to keep them going once they have been approved. Pill testing is a controversy in Australia at the moment about harm reduction, and let's hope Australia finally starts to take that seriously. Harm reduction is ubiquitous. That is to say, it's everywhere we look. Many of you who have come today to this conference will have come by car, and you've put on, I'm sure, car seatbelts, and you travelled in a vehicle that had airbags. This is harm reduction. We do everything we can to stop your vehicle crashing into another vehicle or into a large stationary object. We do everything we can to prevent that, but we can't eliminate that risk. So the next level of defence is to stop the driver and passengers from colliding with the crashed vehicle, and that's done with the car seat belts and airbags. Saved many, many lives. I was visiting the Alfred Hospital yesterday, which is a few kilometres south of where we are now, and I was, this dates me, I'm afraid, I was working in that hospital in 1971 when the block was, the main block in Commercial Road was being built. And I remember, and this was just after car seat belts had come in and into Victoria, one of the first places in the world where seat belts were introduced. And I spoke to one of the architects by chance and asked him how the wards were going to be used. And he said that they had set aside something like 20 or 30 beds for a particular kind of, the treatment of a particular kind of injury that involves, that requires orthopaedic surgeons, neurosurgeons and dentists to work together, injuries of the skull. And now they didn't need those 20 or 30 beds because car seat belts had just eliminated that kind of injury, almost eliminated it. So those 20 or 30 beds for the last almost 50 years have now been available to treat people with other conditions. Motorcycle and bicycle helmets likewise save many lives, pure harm reduction. Harm reduction is very widespread use in road safety policy altogether. Those of you who've wandered through a children's playground recently will have seen that universally in this and many other countries now, the children's playground they have soft coverings on the ground so that the kids, when they fall off a swing or a slide or something, they, instead of getting a break in one of their bones, the kids get a bad bruise. We could take the attitude of not letting kids play in playgrounds, but it's healthy for children to play in playgrounds, so what we do is try and reduce the damage. Australians live in a hot climate. Most people live on the coast. Australians love to go swimming, especially in the summer, and there's some risk involved. People drown. So we have a harm reduction compromise measure. We have, those of you who go to any of the beaches here will see we often have flags, and we encourage people to swim between the flags. Those flags are in the safest area of the beach, and that area between the flags is patrolled. So we don't try and prohibit swimming, which no one would be able to do in this country, but what we do is try and make swimming safer. Condom promotion, exactly the same kind of idea. We do what we can to reduce the risk behaviour, but now the attention is, with condom promotion, is to reduce the adverse consequences, the teenage pregnancies, sexually transmitted infections that happen when condoms are not being used. Many of you will have seen the caps of ballpoint pens, of biros, shiny blue and red caps, and you will have noticed that many of those caps have got a little hole in the top of the cap, and you might have wondered what the hole in the top of the cap on these ballpoint pens is for. Well, the reason is very simple. Little children love to swallow bright, shiny objects and put them in their mouth, and sometimes they will unfortunately swallow those things they put in their mouth. And if they swallow a biro cap that doesn't have a hole in it, that child will die. If there's a little hole in that cap, the child will survive, get to a hospital where somebody can retrieve the object, and the child's life is saved. Generally, harm reduction is extremely effective. All the things I've mentioned do really work, do save a lot of lives, do allow people to lead healthier lives with minimal adverse effects, and are highly cost effective. They're the most important things to remember about harm reduction. But the negative side of harm reduction, not really of harm reduction, but of people's attitude to harm reduction, is worth thinking about. Harm reduction is almost universally in the alcohol and drug field grossly underfunded and very restricted. We should be really doing a lot more with harm reduction. It gets 2% of the government's drug budget in Australia. It should be probably getting 20% of the government responses to illicit drugs. And when we look around the world, needle syringe programs and methadone programs and so on do exist in many countries, but they don't reach nearly as many people as they should. And any new drug harm reduction strategy is universally fiercely resisted when it's introduced, and that resistance lasts for many, many years. And we're seeing that now with the response to vaping, which was the reason for the Cancer Council, Heart Foundation and ACOSH attacking this conference and speakers at this conference so reprehensibly. Instead of sitting down and having a polite, respectful debate and trying to sort out a difference in opinions, they resort to these methods. And that's unfortunately not uncommon in harm reduction. The catch in all of this is that the more attractive a harm reduction intervention is to people at risk, the greater the number of people who will use that harm reduction intervention, which is good, of course, increasing the reach of an effective prevention strategy. Therefore, the more effective it's going to be, but the more attractive it is to people who are taking risks, the more it is resisted by opponents of harm reduction. And this is why we're seeing this vigorous reaction to vaping. The vaping opponents really don't like vaping because it is so good at reducing harm. They want to reduce harm their way, which is by promoting abstinence. We see time and time again that harm reduction is far more effective, far safer, and far more cost-effective than reducing the supply of drugs. We have a dismal record in this country and around the world in reducing the supply of illicit drugs, but when we aim for harm reduction, we almost always succeed gloriously. And generally, harm reduction is also more effective and more cost-effective than demand reduction. That is where we try and reduce the appetite people have for taking drugs. Harm reduction is, we should do demand reduction, but harm reduction is generally more effective than demand reduction. Harm reduction often involves a clinical intervention, that is with one person talking to somebody who's taking a risk, but very often harm reduction is an environmental intervention in the sense that, like the needle syringe programs where we talk to people as well, but we're also trying to influence the whole community to reduce the risk to themselves and to others. And pill testing is another example of harm reduction intervention, which is clinical in the sense of one-to-one intervention, but also has a mass effect, we hope, on all the people attending that event. And this means that our evaluation is much more complicated, much more difficult. Clinical interventions are easier to evaluate than environmental interventions, which we can only evaluate on the balance of probabilities or probabilistically. That is, compared to clinical interventions where we can really evaluate beyond all reasonable doubt. When did harm reduction begin? Well, there's a popular view and there's an unpopular view. The popular view is that nobody never really thought about harm reduction until needle syringe programs began in Amsterdam in the early 1980s, where the Junkie Union, the organisation of people who use drugs, was instrumental in persuading the Amsterdam Health Department in 1984 to adopt needle syringe programs. And then, surprisingly, Mrs. Thatcher's England was soon to follow. And Russell Newcomb in Newcastle claims that he invented the term of harm reduction in 1989, 30 years ago, and he may well be right. So that's the popular view about harm reduction. The unpopular view, which I subscribe to, is that the concept of preventing harmful consequences being more important than preventing use has existed forever. And I can give you many older examples of that, and also examples of text in official documents where this concept, where this argument was played out. But there's no doubt that the new term harm reduction helped people like us to sell the concept of harm reduction in the early 1980s when the threat of HIV was breathing down our neck. Later it became, the policy and programs of harm reduction became a popular social movement, and so they are today, and that's one of the reasons we're gathering here today. The International Harm Reduction Association was established in 1996. I remember the concept being discussed at the meeting in Hobart in March 1996, just as a major political event in Australia was taking place. And then later on, regional, national, and other international harm reduction organisations were established around the world. And then later on, we had a wave of organisations committed to reforming our drug laws, very much needed as well. So that's, in a nutshell, how this whole thing developed. Why is the concept so controversial so often? That's something we have to ask ourselves. And I want you to think about the fact that harm reduction isn't controversial very often in areas like road safety or other public policy areas, but it is always controversial when there's pleasure involved. And drugs and sex are the two areas where harm reduction is so often very controversial. And the concern is that risk compensation takes place. Now, what is risk compensation? The idea is that we all live with a certain amount of risk in our lives, which we more or less accept. And if something changes in the environment so that that risk is reduced, that people will increase their risk behaviour so that the total level of risk that that person is exposed to remains at the previous equilibrium level. That's the theory, and some people believe it. I don't really have any views on the matter, but the concern is that by reducing the risk of using a needle and syringe or having sex while a teenager, that if you reduce the risk, people will do that unwanted behaviour more. That's one of the fears that's driving the concern in harm reduction. So it's always very important when we're talking about harm reduction to make sure that we're doing proper, rigorous before and after studies, before and after the introduction of the harm reduction intervention. One of the problems arising from the antipathy to harm reduction is that harm reduction programs, as I said before, are so often so badly underfunded. Another problem that we have, and I apologise for the language here, is a battle between two schools of philosophical thought. One school is consequentialism. It's called consequentialism, which basically means that we judge policies and approaches by the net effect in terms of benefits and harms of that policy or that approach. So we would judge whether needle syringe programs are good or bad depending on whether there is more benefit or more harm to the community. That's consequentialism, and the commonest form of consequentialism is called utilitarianism. It's not the only form. Another way of approaching the world is called a deontological approach. And the idea here is that we live in a complicated world and we should respect the principles which are the foundation of our community, regardless of the consequences. It's respect for principles which is so common, and many of us will have heard of Confucianism. That's an example of a deontological approach to philosophy. So very often we find ourselves in a situation where our opponents of harm reduction just don't care about the data and the evidence, and this is because they often have a deontological, they've got an in-principle approach to the problem rather than a pragmatic approach which is based on the net impact of benefits minus harms. Apologies, that's a little bit hard to explain, maybe to understand, I hope not, but it's a very important part of the whole harm reduction debate. Another aspect that we've really ignored, I must say, the harm reduction movement has ignored, is that harm reduction really only talks about trying to reduce the harm from drugs in this case. We should really also be talking about maximising the pleasure that people have from drugs and from other aspects where harm reduction policies impinge. Harm reduction in Australia was adopted officially at a national meeting of our then 8 governments on the 2nd of April 1985, and as far as I know, Australia was the first country in the world to explicitly endorse harm. It was called harm minimisation, but this is really what they meant. In Australia, the term harm minimisation then got defined in the 1990s during the Howard period, and it was defined as comprising a combination of supply reduction, demand reduction, and harm reduction. This term is often willfully misunderstood and misused. Harm minimisation is still Australia's official national drug policy. It's used by all the 9 governments now around the country, but the approach is often, frankly, contradictory, and there's serious gaps between the rhetoric and the reality, if I can put it that way. The enthusiasm for harm reduction in Australia and in many other countries has waxed and waned, and we certainly need a much stronger commitment to harm reduction in Australia, but this is now also true in other countries. So seize the iron while it's hot. If your country and your politicians are supporting harm reduction, make the most of it. So what Australia's history of fluctuating levels of enthusiasm for harm reduction is not unusual. So what do we need for harm reduction to work? Well, we need an acronym of Robert West, an English researcher, APPEASE. He uses this for behaviour change, and I think it's a good acronym. We need interventions that are attractive, that the people who we want to use the intervention are going to actually like and enjoy using. We want them to be practicable. That is, they can actually not only be attracted to them, but they're easy to use and they're pleasant to use. They're effective. They do reduce harm. They're affordable. No point in introducing interventions which the people who need them most can't afford. They have to be safe, obviously. And this is something that isn't emphasised much, and I was pleased to hear that Minister Foley emphasised this. They also have to be equitable. The alcohol and drug field, for the most part, is an area that mainly affects everybody, all social and economic groups. But it mainly affects the most disadvantaged members of our community. So therefore, if we're serious about trying to reduce harm from drugs, we have to have interventions that are going to work particularly well in socially and economically disadvantaged populations. So let me wrap up now and conclude. Harm reduction focuses on reducing health, social and economic costs of a risk behaviour without necessarily reducing that risk behaviour. If you can reduce the risk behaviour without causing other problems, do so by all means, but the emphasis has to be reducing the adverse consequences. That's what we're out for. It's used very widely with legal and illegal drugs. It's used widely in public health, clinical medicine, public policy generally. It's not just restricted to the alcohol and drug field. It's contentious, but it's really contentious only where we're talking about a risk behaviour that involves pleasure. Generally, it's remarkably effective, it's safe, it's cheap, but it's often hard to introduce and implement, and sometimes, as I explained, it can be difficult to evaluate. It's more effective than supply reduction or demand reduction, but it's much more poorly funded. And when drug policy fails, the usual reason is that the commitment to harm reduction has been lacking. Thank you very much.
Thank you, Alex.